not here. If this has footrest, make sure that you take the footrest before. Okay? So with the footrest, I'm gonna have Andrew sitting on the table, okay, and have this wheelchair locked. So in neuromuscular one, we did not use wheelchair, or we just like used them very briefly. But with here, you may see during the exam, we would have a wheelchair there. Okay, if you decided to move your patient from here to here, it's not recommended to use this wheelchair, this chair of course. Okay, if you want to use one of those without armrest, that would be fine. Okay, and again, we have the gait belt on your patient. It's going to be the same thing. A little bit loose. Okay. So since he is right-sided, so he's not close to the wheelchair. I know it's very easy to move the wheelchair forward, but I'm gonna try to remind you about the lateral scooting. We did the forward, we did the backward last time, but we did not lateral scoot, right? So now we're gonna do that. But to do it, okay, before we do the scooting, remember your foot's still inside. We don't change our foot position at all. It would be the same every time, okay? And since I'm moving him to the right, I'm gonna be using my right. Okay. Again, my toes and forefoot is pushing his heel this direction outside, and making sure that his leg is not falling into external rotation. So this one is here. Okay. You would not feel okay if you are too far to the left. Okay, so it's better to be kind of like all the way to the patient's here. Okay. Again, the affected shoulder, okay, we need to protect it, right? So it's always there on your shoulder, and the other hand would be there. This is kind of helping my patient to lean forward at the hips. Okay? My hand now is going to be the same way. Okay? So my hands are there. Okay? So I have him facilitated at the back extensors. Okay? And now I'm going to ask him, the count of 3, we're gonna scoot a little bit, slide your body to your right side, right? So on the count of 3, 1, 2. This is the first step. I can tell that he is still away from the wheelchair, right? And now also, I can tell that his feet are kind of not really, the thigh is not parallel to the foot. So I'm gonna pivot a little bit there, and then again, lean forward on the count of 3, you're gonna scoot a little bit to the right. Okay? Now I did that twice, but I feel like he's still far from the wheelchair, right? So adjust the foot, okay? And still support it, right? I may scoot another one. So on the count of 3, gonna scoot again to the right, please. 1, 2. Okay, now I think we are close enough to the wheelchair, so I can do it. Lean forward on me, okay? A little bit more, okay, good. And on count of 3, we're gonna be on the chair, okay? 1, 2. He's now on the chair, okay? He may need to be moved a little bit back, right? We learned last time to scoot him back. So my foot now is gonna be right there, okay? Lean forward. Okay, I'm gonna scoot back a little bit. Okay. Now he is sitting on the wheelchair. Okay, safe. Okay, so Sometimes it's very easy to have the wheelchair close to the patient. This is what we do in the clinical practice. But the video needs you to do at least 2 circles of kind of scooting to the affected side. Okay, so going back. As she said in the video, we always trying to emphasize the neuroplasticity, right? Okay, so at this point, I would take my patient and go to the gym, practice a lot of things at the gym and coming back. So we always transfer our patients to the affected side. All right, so at this point, when I come back from the gym, okay, I'm gonna have my wheelchair kind of locked, okay, and I'm gonna have the wheelchair kind of readjusted to be here. Okay, and lock the wheelchair. All right, and we're doing the same sequence, going back to the, so I'm transferring him to the right. So let me take this, right? This is my foot inside, and this here. Okay, same thing, hands there. You can notice that the wheelchair is kind of lower than the table, so that would be requiring me to move a little back with the left, okay, so not to lean forward. So I have a wide base of support, okay, and my hand's gonna be the same thing on his back extensor as him to lean forward on me. Okay, here, the count of 3, we're gonna scoot back to the chair, to the bed. Okay, 1, 2, and 3. Okay, got him there. Adjust, and then 1 more scoot. Good. He is back again to the table. All right. Questions?
Right side's the affected side?
Yes.
Is that how? That's a little confusing with our PCM instructions. In with
What
the
happened
good.
there?
In with the good, out with the bad. For transfers.
Okay. So you transfer to where? The
Um,
PCM.
Bed, or chair to table.
Okay.
Table to chair.
Okay. And you
Bed.
transfer to which side?
Always.
To the good side? Okay.
Always use
So-
the good side.
Yes, and here in Europe, okay, we're always trying to get the patient crossing the midline. You did transfer for those people and PCM maybe for a patient after hip replacement, right? So with hip replacement, should be okay to transfer because the weight bearing is not a big deal, right, for them. Maybe they start weight bearing the second day, right? But some other people who are not allowed to put weight on their legs is kind of using the less affected side more.
Okay, that makes sense.
Okay, but for us here, it's as I said, we have no restrictions for the weight bearing, and we need our patients to cross the midline. That's what they have a problem with, the perception. So a patient with Usher syndrome, a patient with cognitive disabilities, a patient with visual field deficits, we're always looking for them to cross the midline, right? So we're doing this to the affected side.
Okay.
But this is a good question. Any more questions? No? Okay, let's start the practice.